So I'm Dr. Paul Mulhausen. As Sandy has said, I'm the Chief Medical Officer here at Telligen. And we wanted to spend some time with you today, giving you an opportunity to start learning more about the MACRA Quality Payment Program. Yeah, you may be aware that this first performance period is just around the corner, starting in January 1, 2017. And we thought it would be a great time, 6 months before we all have to start on this, to share this opportunity to help each other learn more. Our goal with this webinar really is to introduce you to the language of the MACRA Quality Payment Program and give you a basic overview of the program itself. There's a lot to master with this particular program. For those of you who have seen the proposed rule, it's over 900 pages long. And really our intent here is to give you a basic introduction and help you to start to master the acronyms and language that will dominate the conversation around the MACRA Quality Payment Program. So part of what we'll do is help you also understand what MACRA is, primarily because I want you to know that it really was the legislation that set up the Quality Payment Program. But I think what you'll find over time is that the MACRA linkage to the Quality Payment Program will sort of gradually be lost. So that MACRA acronym will be gradually lost. And we'll be talking primarily about the Medicare Quality Payment Programs. We also want you to better understand some of the challenges that CMS and, in my view, the medical community seem to be experiencing at this stage in the development of the Quality Payment Program. And to highlight that, in fact, this program is currently in a proposed state, with CMS still receiving feedback, if you want to give it, around the proposal through June 27th. And then our last goal is to help you understand how Telligen might be able to help you succeed as this quality payment program is rolled out later this year and actually implemented during the first performance year in 2017.
And I'm going to interrupt you for just a minute, Dr. Mulhausen, because we've been made aware that some of our registrants did not receive the registration ID that you should have received with the link. So if you did not receive the registration ID, if you will call 515-440-8555, they will give you your registration ID so you can get in so you're able to see the slides. So that phone number again is 515-440-8555. And I apologize for the confusion with this.
Thanks, Cindy. So hopefully those of you who have not gotten the registration ID can call that number and get it. So let's move on to the next slide and start with the basics of MACRA. This would be the Medicare Access and CHIP Reauthorization Act of 2015, known by many affectionately as the law that fixed the SGR, and we'll talk a little bit more about that. So, as you know, this law was signed by President Obama in the spring of last year, 2015. Many people have called it the, quote, doc fix, unquote, because it repealed the sustainable growth rate formula adjustment to Medicare Part B payments. It did some other things as well. It modernized the Medicare payment policy for physician services by stabilizing the base conversion factor, and we'll show you the impact on Part B payments in the next couple of slides. And it also offers the opportunity to update the base rate by 0.5% each year from 2016, so this year, through 2019. And then it streamlines the current physician quality incentive programs. And you may know these well. They are PQRS, the EHR incentive program, which we all affectionately call Meaningful Use, and the Value Modifier Program, and streamlines these into a single quality reporting program for physicians and other eligible clinicians. And Sandy will be telling you more about that as we get deeper into the conversation. Stabilizing the base Part B payment conversion factor by repealing the sustainable growth rate formula really does offer tremendous benefit to practices' revenue stream. You can see here from this slide that if the sustainable growth rate formula had gone into effect in 2015, clinicians participating in Part B Medicare would have had a 21% cut in their base pay for the services they provide under Medicare Part B. And you can see the impact of that in the orange columns here on this particular slide. So instead of experiencing that draconian cut in pay, Part B clinicians are going to receive a series of adjustments that stabilize the base pay rate for services under Medicare Part B and actually positively adjust the rates by 0.5% annually through 2019. It's a subtle effect, but you can see it here in the green bars over the course of progressive years in the future. So this slide, I think, nicely illustrates how the SGR formula was projected to impact Medicare Part B payments and contrast it to the anticipated changes in payment rates that we physicians will receive under the MACRA legislation, as well as other clinicians receiving payment for services under Part B Medicare. Now, just so you're aware that MACRA was more than fixing the sustainable growth rate formula, there were a number of other accomplishments from the legislation through other changes in federal health policy. So it wasn't just about repeal of the SGR formula. Importantly, it reauthorized funding for the Children's Health Insurance Program through 2017. It restructured some payments for both hospitals and post-acute care providers. And it also made changes to the contributions that beneficiaries must make to Medicare coverage. And it's because this was a more comprehensive legislation than just making changes to the physician fee schedule. I think what you'll find over time is that this new program, the Quality Payment Program, will lose the part of the acronym that we affectionately call MACRA, because MACRA had a much broader scope. The MACRA law did, however, also set up this new merit-based incentive payment system that many of us have come to know as MIPS, M-I-P-S. And it also established incentives for clinicians to participate in certain alternative payment models, which now the current language would be advanced alternative payment models. These two incentive paths, MIPS and advanced alternative payment models, give eligible clinicians a choice in their pursuit of payment systems that reward high-value care. MIPS will streamline the current physician quality incentive programs into the single merit-based incentive payment system, and eligible clinicians who participate in MIPS will receive payments linked to quality. The advanced alternative payment model path will offer incentives to qualifying practitioners who substantially participate in certain types of qualifying alternative payment models. Now, the thing to know is that the first performance year for both of these paths is being proposed to start on January 1, 2017. And since most eligible clinicians are not currently participating in a qualifying advanced alternative payment model, most eligible Part B providers, like me, will be participating in MIPS as opposed to the APM pathway. So it becomes very important for you to understand the merit-based incentive payment system, and we are going to take a deeper, Sandy is going to take a deeper dive into the components of MIPS. Now the Quality Payment Program, that is MIPS, and the Advanced Alternative Payment models, incentivizes us, eligible clinicians, toward value-based payment, where pay is linked to value rather than volume. That really is the intent of these quality payment programs. You probably heard Secretary Burwell lay out clear goals to help us move to value-based payment models where 90% of all Medicare fee-for-service payments are linked to quality by 2018. And then half of Medicare payments are actually linked to alternative payment models by that same year, 2018. So MIPS and the Advanced Alternative Payment Model pathways offer a choice for clinicians who are working to transform their practices to succeed in payment models that are linked to value, which is the goal of the Department of Health and Human Services. The Quality Payment Program timeline began essentially back in 2015 when the legislation was signed. But since that time, there have been a series of milestones that, again, you can see date back to 2015. And we're now in the spring of 2016 where we find ourselves in the midst of the Quality Payment Program proposed rule feedback stage. So the proposed rule has been published. Many experts are reviewing the proposed rule. Clinicians out there who have the time and energy to review it are also welcome to provide feedback to the Centers for Medicare and Medicaid Services about its proposed rule. And the intent is to have the final rules in place for the Quality Payment Program by fall of 2016. So in 2016 is when we should have a good sense of what it is that we're going to have to be doing for this first performance year. So again, this means that that first performance year for the Quality Payment Program begins in just 6 months, January 1, 2017. And I can tell by your participation in this webinar that you understand it's time to get ready, and it's time to let your colleagues know that they need to prepare for this date. Now, Sandy's going to take over at this point and give us a deeper dive into the MIPS program, and then I'll come back and go over some of the alternative payment model framework, and then Sandy will be back again to give us some details. So, Sandy, tell us more about MIPS.
Well, first I just want to reiterate that everything that we are talking about today is proposed, which means it's set in sand. Again, as Dr. Mulhausen said, that there is still time to submit comments through June 27th, and at the last slide, I do have the link to how to submit comments and where. That'll take you right directly to that. Or else reach out to your stakeholders and make sure that they're submitting the comments that you feel need to be submitted, because you guys are the ones that are doing this work. All right. So what does MIPS mean for the PQRS, Meaningful Use and Value-Based Modifier Programs? Those current standalone programs as we know them now, they'll essentially sunset, or they'll stop December 31st, 2018, which begins with the performance year. This year, 2016, is the last performance year because the sunsetting is for the payment year. But the biggest change really is going to be that performance matters. PQRS pass-fail system will be gone with the MIPS. There'll be the opportunity to get partial credit in these programs. But essentially, MIPS is just renaming these programs and adapting them. So who is affected by MIPS? One of the new terms that you'll need to become familiar with, and there are a lot of new buzzwords and terms and acronyms, that is EC. You will now be called eligible clinicians instead of eligible professionals. For the first 2 years, 2019 and 2020, ECs will include physicians, PAs, nurse practitioners, certified registered nurse assistants, and certified nurse specialists. Now, this applies to those roles that reimbursement to Medicare Part B. So it's for Medicare Part B clinicians only, those that bill under Medicare Part B. And that seems to cause a lot of confusion out there, so you'll hear us say that several times throughout this webinar. And now 2 years into the program, there'll be additional clinicians added. And this is something that CMS is seeking comment about. You know, should they include social workers and occupational therapists, physical therapists, nutritionists, dietitians, some of those clinicians that were included in PQRS already. But those folks won't be added until 2021. Now, as a MIPS clinician, you will have the flexibility to report or be assessed as an individual or as a group. You'll get to determine that. However, whichever way you decide to go as an individual or group, you will need to be scored for your performance categories the same way. You can't do one performance category as an individual and one as a group. All 4 performance categories, and we're going to get into those in just a few minutes too. Legislation does provide some exclusions. If you're newly enrolled in Medicare for less than a year, if you have a low volume of $10,000 in Medicare Part B charges, and less than 100 Medicare patients attributed to you, then you are exempt. And also, if you are a qualified participant in the advanced APM, you will be exempt from the MIPS. Instead, you'll have the opportunity to get the 5% incentive payment through the APM module. Hospitals and facilities are exempt. With so many critical access hospitals in Iowa, a common question that we get is, how does it affect us, the critical access hospitals, when we're billing methods for some of our providers? And CMS did add some language on the proposed rule in regards to this. They said that those eligible clinicians will be treated to how they function today under PQRS and meaningful use, or the APM program. If an EP works at the hospital and bills any Medicare Part B professional services, so they're subject to MIPS for those services under Medicare Part B. Again, Medicare Part A services are not included. Now, the graphic on the right is a visual of the impact of the Medicare Part B claims. Depending on where the eligible clinician's performance score lands for each performance year. So, for example, 2019 payment year, which is 2017 performance year, just around the corner. So how you're performing starting 2017, if your composite score lands at or above the threshold that will be determined each year, you have an opportunity to get a positive a payment adjustment of up to 4%. And if you fall about in the average, you'll get no payment adjustment. Now, there is also a scaling factor, because I know you're hearing, well, gosh, I'm hearing 12% and those type of things out there. There is a scaling factor. Depending on how the rest of the nation rates, then there's a scaling factor of 3. So if you're a really high performer and you get a 4, and there's not a lot of other ECs in the nation that meet those expectations, they'll multiply that by 3, and you could get a positive of a 12%. And honestly, CMS is not expecting, especially the first year or two, for many folks to fall into that category. Now let's look at the other end of this. If your composite score is below the median, you'll be given a negative, and a maximum negative adjustment is for a -4. There's no scaling factor for that. They do have a separate bucket of money set aside for exceptional performance, but the law requires this to be budget neutral. So those that perform well will receive a positive adjustment, and those that are on the low, they'll receive a negative, and that has the balance at 0. So what we take away from low performers is going to be given to high performers, and if you're in the middle, that will be neutral, and you'll just stay at the current. I know that gets a little confusing, but these are the 4 performance categories which will make up the composite performance score that determines what your payment adjustment is going to be. ETC will get a composite performance score. New acronym for you to recognize and learn is the CPS. The total of the 4 categories sums up to 100 points. Quality is 50. Advancing care information, aka meaningful use, is 25%, and the clinical improvement activities is 15%, with resource use at 10%. Now, clinicians and groups, you will need to submit the information to CMS, just like you're doing for PQRS now and meaningful use. You go in and test, or you register with a registry, and you submit the information to CMS. What they're trying to do to reduce some burden is that for those first 3 categories on this slide, you'll submit through a single reporting mechanism.
Cover up the pizza breath.
If someone would please mute their lines, I would appreciate it. Anyway, and then the last resource category is based on Medicare claims, so there's no reporting requirement for that one. All right, I want to do just a quick breakdown on each of the 4 categories. There's lots of details about those out there. There's still a lot of unanswered questions where they're seeking comments, but we're going to talk about for MIPS year 1. Quality is 50%, and this replaces the reporting of the CQMs to PQRS and the quality component of the value-based modifier program. They've reduced some burden by you only have to choose 6 measures. You don't have to look at domains. And these measures will be some of the existing PQRS measures, and also there's an opportunity for more measures to be added. You'll have to refer those 6, 1 cross-cutting and 1 outcome measure. Now, they do allow options to accommodate for differences in specialties and small practices. So if you're a specialty and you really feel like you can't identify 6 measures, now if you can't identify 9 measures, you kind of go through the MAV process, and it's a pass or fail, for the PQRS. But with the MIPS quality category, if you feel like you only can identify with 4 measures, you just submit those, and you're evaluated on those 4 measures, and you may get a lower score, but it's not all or nothing. They also are planning to have the measures applicability validation. I'm just not sure the components. It's unclear to me in the proposed rule how this is going to work, and I'm really hoping to define it a little bit more in the final rule for all of us. So on the quality, depending on the group size, you'll earn 10 points for each one for up to a total of 80 or 90 points in order to get the full 50 points for quality. So here's the advancing care information, which again replaces the Medicare EHR and SNAP program, and you're going to hear that referred to as ACI. So another buzzword to get used to. There's no longer an all or nothing EHR measurement. There's no thresholds to meet. The measures have an emphasis on interoperability and data exchange, which is making data more readily available to other providers and patients, the registries that are going to report for you, those types of things. You will have to choose the measure Protect Health Information, the Security Risk Assessment. So that is, you will have to choose that one and perform that or conduct that assessment each year in order to pass this. Again, CMS is very, very, it's very important to them, the security for the patient's information that is being submitted electronically. So so that is a must. The overall score is made up of a base score of 50 points, and then you can improve with a performance score of up to 80 points, depending on where you fall with some of those quality measures and some of those thresholds that you meet. And there's an opportunity to earn bonus points. The bonus points have to do with being connected to registries other than the immunization registry, which is going to be one of the requirements, but other registries. Now, currently, under the Meaningful Use Program, nurse practitioners and PAs are not eligible to participate in the Medicare EHR and program. So thus, for the first year, even though they would be considered an EP and MIPS, they will not be required to attest for the ACI category. And instead, that 25% of those 25 points from that category, they'll be spread to the other performance categories. But next year, and going forward, they will be required. So they're kind of, because this is coming out so late, they're giving them a break. Now, if you're already doing this in your practice, or if you're attesting for meaningful use for the Medicaid program, then you certainly, I would recommend that you submit when it's time to submit. Now, just a reminder, again, hospitals and Medicaid EHR eligible professionals will continue to report meaningful use as we know it now with the current laws, the current measures and objectives. The Medicaid clinicians, if they may have to attest to both programs, so they may have to go and attest to their state's Medicaid portal, and then for the MIPS, if they're seeing patients, Medicare patients, and billing Medicare Part B, they will have to submit for that too in order to meet both requirements. Okay, the clinical practice improvement, you'll hear that called the CPIA, and the idea behind this is to reward doctors making changes in their practices and processes that CMS believes are steps to improve patient outcomes. So the clinicians are rewarded for activities focused on care coordination, video engagement, patient safety. We've listed some examples down there of what some of the 90 activities that you can choose from. And each of the activities is weighted. You know, it's a lightweight, a heavyweight, or a full weight. So you have an opportunity to earn that and get to decide that. If you are a recognized PCMH participant, you will earn full credit, or the whole 60 points, making it the 15 points for that part of your composite score. What they're really seeking comments for is, we know out there now there's some, I'm going to use the NCQA as the recognition, but there are other PCMH certified recognition standards also. But for NCQA, we know that there are some practices that are under one Big 10, but only 4 locations have that PCMH recognition. And so they're trying to determine, and that's what they're also seeking comments on, how do they rate those folks if that location is NCQA, but another location under that 10 is not an NCQA certified PCMH. So there's more to come on that with the final rule. And then advanced APM participants, they'll earn at least half of the credit for the CPIA. Resource use. This replaces the cost component of the value-based modifier. The best part of this category is there's no reporting or separate data reporting required for clinicians. The MIPS calculates the score based on the Medicare claims by measuring the total per cost attributed to the beneficiaries and the Medicare spending for beneficiaries for both Part A and B. They're going to use more than 40 episodes of specific measures to account for differences among those. There's a lot of information in the rule about this. I'm not going to go into the details too much other than to say that CMS has taken into account several factors when they're developing these episodes, and they're trying to make them more practice for hospital settings. But they're looking at things like, the clinical problems at the time that the item and the service was furnished, and some of the history and other combination of chronic conditions those patients may have and their current health status. They also are looking at what the relationship for that provider is to that beneficiary. You know, is it their primary provider, or did they just come in and provide some services while the patient was in the hospital? Those are all things that will be part of this calculation. All right, moving on to the second track or path of the payment model. Clinicians who take a further step towards care transformation, participating to a sufficient extent to the advanced APM, they'll be exempt from MIPS, from the MIPS PA or payment adjustment, and they'll qualify for the 5% Medicare Part B incident payment. Again, the APMs are a new approach designed to incentivize the adoption of payment models that move away from fee-for-service. And I'm going to have Dr. Mulhausen go over the APM framework model with you.
Thanks, Cindy. Hopefully you're getting the hang of some of this language, like advancing care information and clinical practice improvement activity and MIPS and advanced APMs, because that really is our purpose here. I also want to let you know about this alternative payment model framework. Now, we have prioritized MIPS in the course of this presentation because, as I said earlier, during the introductory phase, most of the eligible clinicians are going to be participating in the Quality Payment Program under MIPS. But over time, more and more of us will be participating in advanced alternative payment models. And of course, there's a lot to know about advanced alternative payment models and just alternative payment models in general. And there's a lot to know about the requirements for those advanced alternative payment models that would make them available for the incentives for qualifying APM participants. Now, a useful framework here is this APM framework that was developed by a group called the HCP Learning and Action Network. And this framework has been designed really to communicate the qualities of the different types of alternative payment models, ranging from this category 1, which is traditional fee-for-service, up to category 4, which would include payment models that are built around comprehensive population-based payment, or for lack of a better term, capitated payment. I'm not going to spend a whole lot of time on this slide. It's really there for you to be able to look at and study. And if you want to get more information, we will be having a white paper about this framework. And you can also find the HCP Learning and Action Network white paper online. And I guess the real take-home message out of this slide is that potential advanced alternative payment models are likely to fall in categories 3, so alternative payment models with upside gain sharing and downside risk, or category 4, comprehensive population-based payment. So to help us understand more of the details around advanced alternative payment models, Sandy once again is going to share with us what she knows from the proposed rule.
So is your alternative payment model, your APM eligible? Well, to be eligible, you have to participate in a defined APM, as you'll see on this slide, and then I'll go into those a little deeper in a couple slides. You have to use a certified EHR. You have to collect quality measures data compared to MIPS, or the quality category, and then you have to meet established payment thresholds, which we'll talk about that in the next slide. And last, you need to bear the financial risk for monetary losses that are in excess of a nominal amount, and there are some examples and some suggested percents in the proposed rule, and we'll be I know lots of comments about that, and they'll be defining that for sure in the final rule. But if you're in a shared payments ACO, if you're only looking at an upside and not risk, you definitely will not be qualifying for an advanced APM. Now, if you meet all this criteria, then you're going to be considered a qualified participant, and we'll talk about what rewards you get for being a qualified participant in just a few minutes. One of the requirements was that you had to meet certain thresholds, and this slide here shows the thresholds that are announced in the proposed rule. So for 2019, you have to either meet 25% of the payments of your payments for an advanced APM, or at least 20% of the patients the reimbursement is done through an advanced APM. And then that increases, well, in 2020 stays the same, and then that increases. The proposed rule also defines the list on the right as the eligible advanced APMs. So if you are in one of these, the comprehensive end-stage renal disease care model, the CPC, the Medicare Shared Savings Track 2 and 3, the next generation ACO, or oncology care model, then you are eligible to be an advanced APM. Now, just because you are eligible to be an advanced APM, you still have to hit those thresholds that I just showed you on the slide previously to be considered a qualified participant. Now, if you're a qualified participant, then you're not subject to the MIPS payment adjustment. Instead, you'll receive a 5% lump sum bonus for payments year 2019 through 2024. Now, again, you have to qualify each year. And you'll receive a higher fee schedule update 2026 and beyond. And there are such things as partially qualifying QPs where you actually are in one of these eligible advanced APMs. That's been determined that you don't hit the thresholds, then you're considered partially qualifying, and you have the opportunity to decide whether or not you'll just stay where you are with your Medicare Part B reimbursement, or you choose to do the MIPS. And if you choose to do the MIPS payment adjustment, if you feel like you're doing good, high quality, and you're going to fall in the above threshold, you may choose to do that. Okay, moving forward, I'm going to turn this over to Dr. Mulhausen.
So we're starting to reach the end of the road here with our presentation, but wanted to give you a better sense of the timeline and then provide some summary and how to get a hold of us if you have any questions after we come to closure. This particular timeline comes directly from the Centers for Medicare and Medicaid Services, and I think nicely highlights what you can anticipate moving forward with the Quality Payment Program. So I'm hoping that, again, you get a better sense of the flow. You can see that the base rates in that top row for Part B Medicare payments will be adjusted upward by 0.5% over the next 3 years, because the timeline actually starts this year, 2016. It's followed by a period in which the MIPS and the advanced APM incentives will dominate the payment adjustment starting in 2019 and running through 2024. And ultimately lead to additional base rates incentives for advanced APM participants, which you can see there in 2026 and later for qualified APM eligible clinicians. And then you can see that there will be larger penalties and larger rewards for participants in the MIPS program. You can see the gradual escalation of the payment adjustments under MIPS, starting with up to 4% in 2019 payment adjustments, rising up to adjustments of up to 9% up or down by 2022. And then in that last, or bottom row is the correct term, the bottom row, you can see clinicians who participate in the advanced APMs and meet the participation thresholds will receive the lump sum incentive payments that Sandy just described that are equal to 5% of their prior year's payment for Part B covered professional services, and that those qualifying APM participants will be excluded from the MIPS program. So the first performance period starts in 2017. January 1st is the proposed start date, and the first payment adjustments under the MIPS and the APM pathways begin in 2019 based on performance during this first performance year. Sandy, what do you have to say about, oops, went too far. That's next step 5. Anything?
Well, there are some challenges for providers. One of the biggest challenges is just getting the information out there to everybody. We're hearing lots of providers that are unaware of the program and the program structure, and that's part of why we're reaching out to you folks and providing these type of webinars.
We also know that small practices may struggle with some of the administrative requirements and, of course, implementation. CMS, in this proposed rule, recognizes this unique challenge to small practices and does have some resources out there to provide support, and they plan to offer some flexibility to the small practices. I'm also hearing from colleagues, especially those in some of the specialty areas, that the menu of quality measures available to them may not in fact capture the quality of their care, and that there may not be enough measures for them to use under the merit-based incentive payment system. And so CMS is continuing to work on that. And then, as anybody who's participated in the PQRS program knows, quality measure reporting remains a challenge. The proposed rule offers some suggestions for ways to improve our ability to report the quality measures. And of course, the data submission dates there's some possibility that they may change as the program rolls out, and so you'll want to pay attention to that.
I think another good challenge that we have is the nation is improving as a whole, so it is harder to be a higher performer. But we're looking at just some conclusions. Go ahead.
Yeah. Okay, Sandy. So, the main conclusion here is that value-based payments for Medicare have arrived, and it's time for us to get our practices into a position to succeed under these value-based payment programs. The language of the Quality Payment Program and value-based payments is going to be dominated by MIPS and advanced alternative payment models, and it's going to replace the language that we've been using for PQRS, the EHR incentive program, or meaningful use, and the value modifier program. So again, part of our objective here is just to introduce you to some of the new language that's going to be that goes along with these value-based payment incentive programs.
Also, I think everybody needs to keep in mind that technology is going to play a key role in our healthcare future and will continue to do that. Remember, you need to start preparing now by focusing on your existing measures and trying to improve what you're putting into PQRS, the meaningful use, because that's going to prepare you for right around the corner, which starts January 1st with the first performance year, begins just January 1st, 2017. And Telligen has the technical resources and would be happy to help you be successful with your MIPS and your APM adventure.
Journey.
I like adventure.
Oh.
Well, I want to thank, first of all, Dr. Mulhausen for inviting me and allowing me to be a part of this presentation and share some of the information that I'm learning about MIPS and APM. And I want to thank you guys for joining us, especially I know there's not a lot of physicians that have the time to do this, so if you're part of their staff or you just be sure that you share this information with them and know that this is being recorded. And now we'd like to invite you to ask us questions and give you an opportunity to see if we can provide any information that we haven't already shared with you. And the lines are muted so that we don't get everybody at the same time, but just hit star or pound 5 to unmute your line if you do have a question for Dr. Mulhausen or myself.
I have a question.
Okay.
When reporting PQRS, do we report all patients or just Medicare patients? And is there a certain percentage we need to be meeting?
There are not thresholds for the PQRS and that you have to meet. You just submit the data, and it kind of depends on the measure as to whether it's all or Medicare. So, and you can look on the PQRS website to get that information.
Okay. All right. So good. So we don't need to worry about it like 5% or anything like that. Just
correct.
We could be 1 for 1 and be okay.
Correct.
Okay.
And for meaningful use, for this year, there are still the thresholds for the meaningful use objectives and measures.
Okay. Yep. No problem.
Okay. Any other questions? I don't know if that means we did a good job explaining or we lulled you to sleep. But again, thank you for taking time out of your busy days to participate in this with us.
Yes, thank you all for joining us. We'll be sharing more as this all rolls out, as we get final rules, and as everybody starts to implement the program. We'll be messaging and sharing more information to help you all succeed. So thanks for joining us today, and thank you, Sandy, for sharing all of your expertise with us.